The growing recognition that 1 in 5 Canadians will at some point in their lives experience mental illness hopefully also means less stigma and that more of those who need care seek it. But with resources already stretched, meeting those needs, yes, requires resources, but also ingenuity. Joining us now to examine how access to mental health care in Ontario is evolving. In San Francisco, California, Chakame Shafi, co-founder and CEO of Tranquil.com. That's an online platform she created to deliver cognitive behavioral therapy. And here in studio, Rebecca Fortin, a public health policy analyst and 2017 Munk School of Global Affairs Journalism Fellow, and Paul Kurdiak, psychiatrist and clinician scientist at the Center for Addiction and Mental Health, that's CAMH, and a director of health outcomes for the Medical Psychiatry Alliance. Good to have you two here in studio with us on TVO tonight. Chakame, good to have you in California. I know you're from here originally, out there on business, but get comfortable, I guess I would say, because Paul, I want to start with you and spend just a little bit of time with you, setting the table for the broader discussion to come. And let's start with this. How long does the average Ontarian who needs psychiatric care have to wait now before they can get some help?
Well, the sad answer to that is we don't know. Unlike other areas of the healthcare system where wait times have been developed for, to monitor access and accountability, that's virtually absent in the mental health system. There are some studies that suggest that access is quite poor, and I would refer to a study by a colleague of mine who recently passed away, Elliot Goldner. And very briefly, he did a study where he had a research assistant pretend that she was referring a patient from a family health team in Vancouver. And the bullet point of the study is, out of the 230 psychiatrists who were seeing patients in Vancouver, 6 were available to see the referral patient in a reasonable time.
What's a reasonable time?
Well, I think they was in 2 to 3 weeks.
In 2 to 3 weeks. So basically you're saying 95% of the people would have been waiting months.
95% of the people were not seeing patients.
Oh, so would not have been able to get any access, period?
Correct.
Okay. And do you have any reason to believe that that is not indicative of the situation here in Ontario?
I think we'd see similar findings. Maybe not the same 95%, but I think we would see that it's very difficult to access psychiatrists.
Here's you in the Canadian Journal of Psychiatry from, when is this? This is about a year ago. You wrote the following: the supply of Ontario full-time psychiatrists is not equally distributed across the province, with many more psychiatrists practicing in Toronto and Ottawa than in suburban or rural regions. As the supply of psychiatrists increased, the proportion of psychiatrists adopting low-volume practices increased. For example, approximately 10% of full-time psychiatrists in Toronto see fewer than 40 patients annually, compared with 4% in low-supply regions, and approximately 40% of full-time psychiatrists in Toronto see fewer than 100 patients annually, compared with 10% in low-supply regions. Okay, this basically sort of confirms what our supposition is, which is it's easier to get seen in the big cities than it would be elsewhere. But those numbers, and I don't know, this is your business, so you tell me, those numbers seem like fairly low numbers in terms of a psychiatrist's patient roster. Are they?
They are low, and it has to do with the style of practice among the psychiatrists who have those low rosters.
Does it mean that even though the rosters are low, these patients are being seen quite frequently, which explains why psychiatrists can't take on new patients?
Correct. In the original study that cited those, which was in 2014, all the psychiatrists had to be full-time, which means that they had to have virtually the same number of visits seen. So those psychiatrists who saw fewer than 40 patients were seeing them very, very frequently.
And do we infer that the 40 patients probably present very complex, difficult to serve cases?
In the original study, that was not the case. The patients that were seen in this low-volume, high-frequency practice predominantly resided in high-income neighborhoods and had virtually never had a psychiatric hospitalization.
So what, do we call these folks the worried well?
I don't call these
no, you
folks
don't, but is that the colloquial term?
I think people have referred to them as the worried well. Yeah.
You don't like that term?
I don't like that term for a number of reasons. As it relates to the study, the data that I have access to do these studies is very crude, so I don't really have a great measure of need.
Why would suburban or rural psychiatrists, I mean, are they more likely to have fewer clients or fewer patients going to them?
The suburban and rural psychiatrists work in areas that are low supply. And I'm glad you said suburban and rural, because a lot of people reacted to the study as a rural phenomenon. That's not the case. Both Mississauga and Scarborough are low supply areas. These psychiatrists are far less likely to see have low volume practices. And I don't know really why that is, because the nature of my data is that it's good at telling me what's going on, but very poor at why. But one thing I speculate is that if you work in a low supply area, you are less likely to have a solo practice not attached to anything, and you're more likely to be working in a hospital setting or attached to a community agency. And I do believe that being attached to a hospital or an institution of some sort that provides healthcare and mental health care provides some sort of built-in accountabilities that aren't necessarily there for solo practitioners.
Tell me if, I mean, this makes common sense to me, which means it might not necessarily be true. So you tell me, if we want to see twice as many patients as we do today, should we have twice as many psychiatrists?
I think that was the big issue that the two of my studies raised, and the issue has to do with style of practice. If we generate more psychiatrists, but they end up practicing in Toronto and furthermore adopt low volume practices, that's going to make a trivial dent in the access problem. And one thing that I wanted to sort of generate is a larger debate about what the role of a psychiatrist is in a publicly funded system and who they should be seeing.
In which case, let's finish up on this. There's probably two ways to help solve this problem. One is to incentivize psychiatrists to see more people. The other is to force them to do it. What do you like?
Well, so obviously, I would like, that's a tough question, because in the US, we have HMOs that are much more prescriptive about what psychiatrists do and don't do. And the job satisfaction amongst psychiatrists in the US who participate in HMOs is quite poor. So I would like psychiatrists to retain some freedom in how they practice, but when you get to the patient level and see how poor access is, you want them to respond to the need in ways that are other than what we're seeing within my data.
Sounds like what you're saying is you'd prefer the carrot, but the stick maybe if necessary.
Correct.
Okay, gotcha. All right, thanks for your patience, everybody else. Chakame, why don't you come in here right now and tell us, I need to know more about this system that you've developed here. It's a website called tranquil.com, and I want to spell it because it's not the way you think it's spelled. TRANQOOL.com. What is that?
Yeah, so Tranquil is an online counseling platform. It is designed around an evidence-based type of therapy called cognitive behavioral therapy. And what Tranquil does is it matches people up with therapists. The therapists are either clinical social workers or psychologists. And then it allows people to have their sessions from the comfort of home without wait lists and at a much more affordable price.
And did you develop this site?
So I'm one of the founders. I developed it with my two other co-founders, and now we have an amazing team back in Toronto who are working on it.
So you're the engineer behind it, yes?
I'm the one who had the issue. I had personal experience with therapy and the struggles of trying to find a therapist. And so I went to my two other co-founders, and we kind of quit our jobs to start Tranquil.
And how's it going?
It's going great. It's so heartwarming. Like this morning, I woke up and there was an email that we got from one of our customers saying that she has social anxiety and depression and she couldn't leave her house, and that by being able to just have her sessions from home, and just within 2 sessions, she's like, I already feel better and I'm going to be able to leave the house today. That's the kind of things that's just so heartwarming, and it just makes us feel better because that person might have not been able to get the help they needed otherwise.
Can I ask a horrible capitalist question here? How do you make money off this?
Yeah, so that's a good question. It's not a horrible question. So we take, basically we charge the therapist a percentage of the sessions for providing the services that we do, which is booking, scheduling, payment, invoicing, and all that stuff.
Interesting. So not the patient. It's free to the patient, but the clinician is the one who's charged. Is that right?
Well, the therapy sessions are not free, although they're covered by extended health insurance. The patient just pays for the session, and then we charge the therapists. Yeah.
Right. So, I mean, the use of your service is free to the patient, not the session. I didn't mean that.
Yeah.
Got it.
Yes, it's free to sign up. Yeah.
Kind of a silly pedestrian question here, but Tranquil. Why are you spelling it that way?
So I always start it with making a joke about it. It's 3 engineers trying to do branding. But it's when we were deciding, we were looking for something that presented tranquility and at the same time making therapy a cool thing, because honestly, it was life-changing for me, and it was the best thing that I did for myself. So we wanted to make it cool. So it's kind of like tranquility, that's cool.
And again, just finally here before we get Rebecca into this, I don't want to pry into your privacy if you don't care to talk about this, but if you do want to let us know a little about why you felt you needed those mental health services to begin with, which therefore led to this development, we're all ears.
Yeah, so as I kind of mentioned, I'm an engineer and I went to engineering school, and I think throughout school I had anxiety, but I never called it anxiety because I was surrounded with a lot of people who had it too, and it was just being nervous and not being able to sleep. And it was only after that I got a job and I was working that my anxiety got to a point where I felt like this isn't normal anymore. I went to my family doctor and she prescribed some medication, and I just quickly got home and I Googled it and I was like, there's no way I'm buying this because there's so much side effects. And my aunt actually told me to try therapy, and I had never thought of it, and it took me 3 different therapists until I found someone that I really liked, and I was introduced to the whole world of cognitive behavioral therapy. And so I had anxiety, which meant that, you know, day to day, maybe people didn't even know that I had anxiety, but I would go to the bathroom and I would just like have a panic attack once in a while. And it was just like it was messing my sleep and my eating. But it was so interesting that without taking medication and by just doing my CBT, because my anxiety wasn't severe enough, that by just doing CBT for a couple of months, I was not only able to manage my anxiety, but I got the coping skills that I needed. But then I was able to like deal with things so much better than everyone else around me. And so I started telling everyone that they should do CBT. and I heard the same answer from everyone. They can't afford it. They can't leave their job because they have a 9-to-5 job. I did too, but I was able to just work around it and leave work early sometimes. And also they felt stigmatized, and they didn't want to sit in a waiting room even if they found the right therapist. So I was in search for something for my friends and family when I realized we need video therapy back in Canada. And it exists in Europe and in other places in the world. And so we just needed to make it available for Canadians.
Necessity being the mother of invention, you invented it yourself. There you go. How many people do you estimate you've helped through the creation of Tranquil.com?
Yeah, so we have over like 3,000. Actually, when we first spoke, I thought it was around 2,700. And I checked today, it's like over 3,000 people who've used Tranquil.
Gotcha. Congratulations. Well done.
Thank you.
Okay, Rebecca, here we go. Children's Hospital of Eastern Ontario. You have a relationship and a connection to that place. What is it?
Sure. Yeah, I had the privilege and opportunity to report on a brand new program that's been instituted at CHEO, as well as the Royal Mental Health Center in Ottawa. And so they are establishing a new program called Choice and Partnerships Approach, CAPA for short. And what's exciting about this new approach in psychiatry is that it will sound common sense when I explain it to you, but it really turns psychiatry on its head. So instead of a patient getting referred to a psychiatrist in the hospital and waiting the long months to see that one psychiatrist.
And it can be months,
And it can be months. And prior to this being implemented, patients were waiting 6 months, 7 months, up to a year to be seen by a psychiatrist in the hospital. What they've been able to do is reorient and tap into the allied health professionals within the hospital. So the psychologists, the social workers, the occupational therapists. And the patients then come in to what's called a choice appointment. And they sit down with the clinician and they discuss what is the most pressing problem to them at that moment. The diagnosis might come a bit later. Medication might come a little bit later, but in that first session, it's just sitting down with that clinician and coming up with a plan to address that important issue that's troubling the patient.
So you may not see the psychiatrist right away, but you'll see somebody right away.
That's correct. You'll
First
see
contact, quickly.
First contact. And for a lot of patients, that's as much as they need. And they're able to go back in the community, practice some of the skills. They're able to be connected with community services to address that big problem that's facing them.
Okay, in the same way I asked Chakame about necessity being the mother of invention, how did you discover a problem, consider a solution, marry the two together? How did this come to you?
Well, it's an interesting story. So the choice and partnership approach was developed by two UK psychiatrists, and actually it first came to Canada in Halifax. Dr. Kathleen Pager was the psychiatrist, chief of psychiatry there, and her team were struggling with the same things that we're talking about today, is the long wait lists to being able to see the patients that are in so need. So they looked at a bunch of different models and thought this one had promise, and so they started implementing it. And because it was so successful in Halifax, CHEO recruited Kathleen, Dr. Pager, to come to Ottawa, and she brought the program with her and got all of her colleagues excited about the program, and now it's being utilized by the Royal as well as hospitals around the area. And I spoke with some of Paul's colleagues. At CAMH, they're starting to look at Kappa-like strategies, and community agencies as well are starting to look at the model.
And if people want to Google Dr. Pager, it's P-A-J-E-R, right? Yeah. If they want to Google her. Okay. How long are your younger patients at CHEO now waiting under this new way of doing business compared to the way it was in the past?
So essentially the wait times are 0. So with the wait times now are around 2 weeks. If it's something urgent, a patient can be seen within a couple of days.
What's the impact?
The impact is huge, not only on a systems perspective and having people seen sooner, but the program is also improving quality as well. The centerpiece of Kappa is really a patient-centered approach. And so it's really tuning into the family and the patient and what their needs are, and being able to help them set up a plan that makes sense for them.
This idea is presumably exportable anywhere, isn't it?
Oh, certainly, and certainly, like I mentioned, other hospitals around the province are looking at it, and a lot of community health agencies, mental health agencies in the community already do this. They have a lot of expertise with child and youth workers and social workers, and when they do need a psychiatrist, they do tap into that resource when they need.
Paul, let me get you back into this. You are not just CAMH, but you're with a group called the Medical Psychiatry Alliance, and that alliance has something called the Partners Project.
Correct.
What is that?
Yeah, so I have to say I'm not primarily responsible for it, but my colleagues are. The Partners Project is yet another type of innovation where we use different types of professionals, and in this case technicians, to deliver service, and the role of the psychiatrist is modified from the traditional role. The Partners Project is connected to a number of different primary care providers. These primary care providers can refer for depression, anxiety, or substance use disorders. There will be a standardized assessment, and the trick with the Partners Project that differs from traditional care is that there's the use of a technician. This is not a regulated mental health professional like a social worker. It's actually just an undergraduate who's trained. And standardized evidence-based services are delivered through the technician with oversight from a psychiatrist. So the cases, there's case conferences. But because of that indirect care via a technician, there's cost savings because the cost of the technician is substantially lower than the cost of a psychiatrist, and that psychiatrist can see thousands instead of hundreds.
So essentially what we're talking about here is better management of existing resources.
Correct.
You don't need vast new sums of money in order to implement this.
Yes, as long as you have, in Rebecca's case, existing allied health professionals, or in Partner's case, the ability to hire and train technicians, then you can have the emergence of a system where you can align intensity of treatment with need. You can first establish need, which is not currently evident in the mental health system, and then provide stepped higher intensity care as needs occur.
And is the verdict in on the Partners Project yet?
still under evaluation, but there is a wealth of evidence for interventions very similar to partners. It was adapted from a robust evidence-based type of intervention developed in the U.S.
Shakame, coming back to you right now. You told us before that as many as 3,000 people have been helped by your new development and are getting treatment and service in a way that works better for them, in a way that they certainly couldn't before. Can you give us a sort of a broader sense of what kinds of conditions they are seeking treatment for? Let's start there.
Yeah, so CBT, cognitive behavioral therapy, can treat a wide variety of mental distresses. So things like anxiety, depression, low mood, stress, sleeping problems, some levels of eating disorders. Those are the relationship issues. Those are the problems that people come to Tranquil for. The most common issues, and I think a lot of us can predict, is anxiety and depression. And then after that, it's things like self-esteem and relationship issues. And the way we're able to help them is we cater the relationship between them and their therapists based on their needs and the style of therapy that they like. And by style, everyone does CBT, but it's more so like the therapeutical methods that the therapist would use.
Now, Paul, help me out with this. This obviously is good and works for some. I presume this kind of, I don't know if you want to call it telemedicine or telepsychiatry, I presume it's not going to work for everyone. Is that fair to say?
I think that's true, but I think it is certainly a way, internet-based cognitive therapy, the kind of platform that Shakame has developed, even though it doesn't work for everybody, it is certainly a way to vastly expand access that doesn't rely on traditional services.
So as we look at that jumbotron there, it's a piece of the puzzle.
Correct.
Okay. Is it an increasingly larger piece of the puzzle? The reason I ask this is, every aspect of the healthcare system wants more money. All right, hospitals want more money, doctors want more, nurses, everybody wants more money. The fact is, we're going to spend $53 billion in healthcare in Ontario this upcoming fiscal year. We could double it and it would still get swallowed up just like this.
That's exactly
so
right.
We've got to look for alternative ideas, alternative ways of managing things in order to make progress. Is that fair to say?
We definitely have to innovate, and we have to innovate in a way that is evidence-based, that is buttressed with very sound evaluation, so that evidence is generated when you innovate. And most importantly, and this is where we often fail in Canada, we have to scale up once we've generated evidence. We often fall short on that mark.
How do you scale up?
Well, it requires more systematic oversight. Rebecca described a really innovative way to deliver services for children and youth in Ottawa. And I think you're reaching out to people, but there's not really great oversight to say, this is working in Ottawa, this needs to be scaled up, and to be scaled up in a way that allows us to evaluate to make sure that it's what works in Ottawa works in the rest of the province.
You want to weigh in on that, Rebecca? How do we once we know something works in one location, how do we get the word out to make sure we can explore it elsewhere as well?
Well, certainly diffusion of innovation is what's going to be happening with these innovations. The concern for me is what the butterfly effect, what other things are happening causing effect to this. So thinking about what's happening in the community, in these community agencies. And I spoke with the Children's Mental Health Ontario, and they represent over 90 mental health agencies in the community. And even though that these great things are happening in Ottawa, there's still really long wait lists for community mental health agencies in Ottawa. So children are waiting up to a year, year and a half. So
children of what ages?
Children and youth up to 18.
Up to 18 and as young as?
And as young as toddlers, young as 5 who are waiting for treatment. And so there needs to be attention to the broader context of where these innovations take place, and see how we can make sure that we support the whole system, not just the hospital system.
Shakame, I don't want to infringe on anybody's privacy here, but I would like a better understanding of who uses your service. Can you give us a sense of gender, age range, location, that kind of thing?
We're only available in Ontario currently, and so our users are scattered across Ontario. People come to us sometimes because they're on wait lists. They come to us because their physicians have told them about us, or they come to us because their counseling center at school has told them about us, or sometimes they just look for alternative therapy methods or look for psychologists and they can't afford those prices, and they're able to find a good alternative on Tranquil. So, you know, paying $80 to see a clinical social worker or $120 for a psychologist is extremely low if you compare it to in-person therapy and our standard. But that's still a lot of money for a lot of people if they don't have insurance. And we've done our, you know, we're fighting our fight in terms of keeping the prices low. But in terms of when we talk about spending, you know, the budget for CBT specifically, the budget for helping with the mental health system, being able to support people who are on wait lists and not just relying, you know, sending them out into the community, hoping they can afford therapy, and hoping that someone else is going to, you know, help with that and eat that budget is something that we really need to talk about when it comes to our fundings from the government and in our public health system. And we deal with that all the time. We get people sent to Tranquil, and you know, they can't afford $80, they can't afford $120 to see a psychologist, and we're the ones who have to provide the sliding options, and because they don't have insurance, and we can't say no to someone who needs help, right?
Right. How about in terms of certification? Did you need the Government of Ontario to put the Good Housekeeping seal of approval on your website or anything like that?
So the IPC, so the private, like the information commissioner had to do it because you know, we're collecting some data and we have some personal health information from our users. So in terms of information security and privacy policies, yes, we did. In terms of the type of therapist that we have, that was just us going after the colleges and talking to them and understanding which type of therapist can provide CBT really well, which type have had some education in CBT, and what kind of therapists can actually do video therapy. And then we do train them as well, but not necessarily the Government of Ontario like putting a seal of approval on Tranquil because we're not connected to the public system.
Gotcha.
And it's very difficult to get connected. We've tried.
Yeah, I can imagine. Paul, down to my last 30 seconds here. As much as these may be innovative approaches to mental health care, do we have to conclude at the end of the day that maybe psychologists can do their part, social workers can do their part, family docs can do their part? At the end of the day, is it still best to be treated by a psychiatrist?
I think each of those professionals have a role. You know, I think that, and they have different training, they have different mandates. And I would say that it's best for each one of those professionals to serve their role. And it goes back to what I said before. It's not so much who is best at providing what service. It's that how do we align all of our resources in a way that's both equitable and efficient. And what I'm seeing, just as it relates to psychiatrists within the information that I have access to, is that we're falling far short of that ideal.
Understood. Thanks all for joining us on TVO tonight. Shaka Mashafi, Tranquil.com, Tranquool, because it is cool. Tranquil.com is her website, and addition to the field we have discussed tonight, Rebecca Fortin, the Monk School of Global Affairs Journalism Fellow, and Paul Kurdiak from CAMH. Great to have all of you on TVO tonight. Thanks so much.
Thank you very much.
Thanks for having us.
Help TVO create a better world through the power of learning. Visit TVO.org and make a tax-deductible donation today.